We're about to perform a lumbar radiofrequency ablation on this young lady who was an 18-year-old motor vehicle accident passenger who developed somewhat subacute to chronic pain emanating from an accident earlier this year in April of '05. The pain is predominantly within her low back, extending down both thighs, and there is a component of pain which is greater on extension than flexion. Previously, we've performed medial branch blocks at the L3 and L4 level bilaterally, as well as blockade of the L5 primary dorsal ramus. This effectively anesthetized the L4-5 and L5-S1 joints bilaterally. Following these blocks, the patient had little or no residual pain, so we term this an effective positive diagnostic block. Today we're going to radiofrequency the left-sided nerves, namely the left L3 medial branch, left L4 medial branch, as well as the left L5 primary dorsal ramus. We'll come back and cauterize the right side on another day. And we're going to use a small fenestrated drape. We're going to place our needles. Conscious sedation is being provided by an anesthesiologist at the top of the table. And I'm going to mark the skin so that we're just inside, or just medial, to the medial aspect of the iliac crest. Now, right there is going to be my approach. I'm going to mark the skin there to there, and then ipsilateral oblique it, stop. So now, right now, I have a straight line between the image intensifier, the skin surface, and the small skin prick, I'm sorry. Depending upon how awake we keep the patients, they'll feel that little skin prick. I just give a little bit of light to a relatively thin patient. It would be appropriate to also use a 20 gauge. I like a 10 millimeter active tip. Now we're going to set up our, that's a little bit high. I'm going to take that needle right down to the bone. And we can go a little higher than that. Now what we're going to do, we're going to cranially tilt our image intensifier to square off the sacral base and the L5-S1. And then we're going to, right about there, it's beautiful. And now we're going to ipsilateral oblique it to me to set up our target point. That looks pretty nice right there. So I'm really just at that area between the superior articular process and the sacral base. So now in order to go to the L5, our target point is right about there. We're going to go one level down to the transverse process of the subjacent vertebral body, and we'll go as lateral as we can on what would be the transverse process of L5. You'll notice that that would put us just over the iliac crest, so we're going to cheat in to about right there. So I'm going to mark the skin right about there. As I mark the skin there, you'll see where that places me, just medial to the iliac crest. Cranial tilt to there, stop, and a little ipsilateral oblique. Good. Now we set up our target point. Again, I'm going to make a small skin wheel. Tiny little pinch, sweetie. Tiny pinch. I like to use sharp-tipped RF needles that are curved, again with a 10 millimeter active tip. And if the patients fight you a little bit, that makes the trajectory a little bit more difficult. It's okay. So I'm down to bone. Okay, so I'm one level down to my target point out at the tip of the transverse process there. Okay, so now we're going to quarterly tilt our II, or image intensifier. Keep going, keep going, keep going. Stop. And ipsilateral oblique. That's pretty good right there. Very nice. Okay, so we're going to raise one more small skin wheel. We'll then do sensory or motor testing. For those of you who are just starting, again, it's more important to test than be sorry later. 1 and point 2, and we'll start here at L3 medial branch. We're going to turn the machine on. Yes. And we have an excellent multifidus there. Okay, so then we're going to go to L4, and I'm going to check this right here, and turn the machine on. Very good. And here we are at L5. Occasionally you get a response at L5. It's not common, and frequently you have to place your needle anatomically. If you don't want your needles in the way, it's easier to start from superior to inferior. And in that way you can perform your burns Okay, can you enlarge that, please? Okay, so that's really pretty good placement there. The electrode for the first one, we'll take that right there. And we'll go 80 degrees for 60 seconds. And we'll ramp up slowly. And the reason you ramp up slowly is so that you don't cavitate your lesion. You want a smooth burn in an ellipsoid formation so that you get a nice burn around the exposed portion of your radiofrequency needle. Again, the rest of the needle is Teflon coated, so the burning is just done just along the bone, along the projected course of the medial branch itself. Okay, take that right there. This is our second lesion at L3. Take that there. And we'll go to the next level. And after doing the burn with the needle facing medially, I'm going to take the needle and rotate it about 90 or 120 degrees so that the curve faces more infralaterally. And then finally I'll pull the needle back a couple of millimeters and try to capture the nerve a little bit more distally in its course. Again, you want to catch the nerve before it dips down deep to the mamello accessory ligament, where it would be very difficult to cauterize the nerve itself. So you want to catch it just from that ridge to a couple of millimeters more caudad. You can heat anywhere from 80 to 90 degrees. I've found less neuritis heating at 80 degrees. And you can heat from 60 to 90 seconds, with the caveat being that at 60 seconds, you're probably about 94% in the burn radius you would be at if you went for an additional 30 seconds. And for that reason, I'd just rather do a couple of extra burns rather than making a bigger hole.